I'm here with John Kanellopoulos, a member of the ASCRS Refractive Clinical Committee. John, you always talk about interesting things, but I mean, today I think at least for me, is just a super interesting topic. We're going to be talking about TMR. What is TMR?
TMR is a surgical application of things that we learn from topography-guided ablations, and it stands for Topography Modified Refraction. It's a tool that we have been using the last 5 years, and from lessons learned in treating irregular eyes. When we treat irregular eyes, we have come to respect the topography-given amount and axis of cylinder. So the patient's refraction, of course, is critical in treating those eyes, but we have to obey the topography amount and axis of cylinder. So how does this apply to virgin eyes, regular myopia? It does actually if you are doing topography guided, because even normal slight amounts of astigmatism, if they are in patients who have slight angle kappa, meaning 100, 150 microns, and these data are available on all topographies used, the Pentacam, the Placido disc topographies, are important because the topography device in topography guided is going to normalize the cornea on the vertex. So the question arises, are we going to treat the clinical refraction before normalizing this cornea, or should we take the topography data in mind now that the cornea will be normalized by the topography guided ablation?
When we gather data from wavefront, we're gathering it along the patient's visual axis. When we're doing topography, the topography is not normalized. It's not centered upon on the patient's visual axis. It's centered on the apex of the cornea generally. The apex of the cornea is not exactly aligned with the patient's visual axis, and depending upon the angle kappa, can be really pretty significantly off. Significant in the sense that the non-alignment of the topographic normalized center from the patient's visual axis is going to induce coma. Now, coma is not something that we directly compensate for when we do a manifest refraction for the patient, but the patient may choose some degree of cylinder that can partially compensate for it. And we have to deal with the cylinder and non-alignment and all of that sort of stuff when we do topographic guided LASIK, because the topography is not centered with the patient's visual axis. I have absolutely no idea whether what I said made things more clear, but that reiterates what you just said.
It's very hard to explain verbally because this is really a topography issue, but I agree with you totally, and you described it very well. The topography data show us the apex of the cornea and the vertex, which is theoretically the part of the cornea that the patient is seeing out of, the center rather, of his visual function. So that difference, vertex to apex, over 100 microns, is in pretty much every normal human. We have learned to consider angle kappa of over 0.5 millimeter significant, but when we're talking about visions in the level of 2015, 2010 even, it tends to be very significant. If we're doing wavefront optimized, simple laser, which is great, it has excellent results with most laser platforms, this error of angle kappa, and as you mentioned, the patient's compensation for it follows through, and it doesn't really matter. But if you're going to normalize the cornea with a topography guided ablation, that cornea is going to be normalized on the vertex of the patient. So the refractive data will change. And we're seeing this in a contralateral eye study presented here at the American Academy. We received for the same data the best poster for the ESCRS just last month in Vienna. We're looking at a very large group of patients, 100 patients, randomized one eye to receive standard clinical refraction topography guided LASIK, which has been shown internationally for many platforms to work excellent. And on the other eye, use TMR. So what we did in the other eye, we tweaked the clinical refraction with the amount and axis of cylinder that the topography provided. And of course, adjusted angle kappa. In most patients, you treat actually more cylinder than the patients pick up in the refraction. It's a leap of faith if the axis is off more than 5 degrees, we've encountered patients that the axis was off 45 degrees. This is compelling clinical data. And we have found that the TMR eye performed at least one line better. The standard treatment eyes were a little bit better than 20/20. The TMR eyes were invariably 20/15 or better. So these data are compelling, and I think it changes our concept of what clinical refraction is. Clinical refraction is a performance. With the topography-guided platforms, we're learning more on how to improve that.
It's unbelievably interesting. Yeah, really, really, really neat stuff. And, you know, as an additional benefit, your patients are actually seeing better. But it is really, really interesting. John, I want to thank you for bringing this wonderful topic to us. And as always, for being so very generous with your time with us.
Thank you, Josh. It's my pleasure.